This is endovascular treatment of symptomatic acute internal carotid artery stenosis with proximal protection. This is a case of a 62-year-old who presented to the emergency room with transient left-sided numbness and weakness, was neurologically intact on examination with atherosclerotic risk factors on aspirin, Plavix, and metoprolol. CTA confirmed severe right ICA stenosis greater than 90%, and duplex velocities were severely elevated with right-sided peak systolic of 418 and end diastolic of 140 centimeters per second. CT perfusion suggested increased time to peak throughout the right hemisphere with preserved volume and flow. CTA confirmed a severe critical stenosis, mostly soft plaque with mild calcification. Angiogram access was obtained through the left side with external carotid artery visualized through a common carotid injection. The first step engages the external carotid artery through direct catheterizations through a Simmons 2 catheter. The Simmons 2 is advanced into the external till we have distal access into, in this particular case, the occipital artery, and then the Simmons 2 is exchanged out for a stiff 035 wire. We like the supercore super stiff wire to facilitate delivery of the 9 French proximal protection MoMA system. As you can see here, the MoMA balloon guide has been positioned in place. Once in place, the 035 stiff wire is removed and a common angiogram is performed. The balloons are prepped in the external system. In this case, as you can see, we have inflated the common balloon followed by the external balloon. Flow stasis is confirmed, as you can see here, and then the lesion is crossed under complete flow arrest through proximal protection. The TUI typically is open at this point to allow for some back bleeding. Once the wire is across, we usually advance the wire over the balloon and perform optimal plasty, typically right size to the internal carotid artery. Post-plasty, we then advance a stent. For symptomatic lesions, we like closed cell. In this particular case, this is the wall stent. The first part of the stent engages the artery through just simply unsheathing, and once it's engaged, we then try to push to allow for optimal opening of the stent. As you can see in this case, we just crossed the lesion, and now we are deploying it into the common primarily through a pushing technique. Once the stent is completely deployed, the stent delivery system is removed and intravascular ultrasound is brought in to confirm full patency of the vessel. As you can see in this cross-sectional and sagittal reconstruction, this is the part where the stent is located with the hyperechoic stent tines and back into the guide. Once we have confirmed patency on IVUS, we then aspirate 3 aliquots of 20 cc's of blood to make sure there's no debris there, and then restore flow, opening the common balloon first and then the external, restoring flow and preserving intracranial vascular circulation.